because so I can go back to the UK and do some publicity for them because you've got a great country. I'm really impressed with what I've seen so far, and I hope this will be one of many, many more trips. So I'm a surgeon from London, and as the surgeon, one of two surgeons on the team, I thought, well, we're the most important people in this in this group. So I thought, well, when I was given this talk by Simon, I thought, how am I going to make this interesting? Well, I thought, well, because I'm the surgeon, or one of the surgeons, it has to be the most important talk of the whole 2 weeks, okay? So it's really important. So it's going to be a brief introduction. I think we've got about sort of 30 minutes or so. We'll try. I will skip through one or two slides, so don't be upset. Don't feel shortchanged. You have all of this in your app already. And if there's anything you specifically want me to, cover, ask questions. The most important slides, I will spend a bit of time and say, look, this is what you need to learn, okay? So we'll talk a little bit about, some definitions, comorbidities, performance status, and its role in cancer, a little bit on some measures and some specific applications in cancer management, and then we'll summarize and conclude. So as a surgeon, I thought, how am I going to make this interesting? So surgeons always like to put pictures of their hospitals, reminds us how important we are. So this is St. George's, not as nice looking as as Guy's and King's. So I did my PhD at King's. I have a long association with King's College. I still am involved in some research there, even though I'm just down the road. Tooting is actually one of the nicer parts of London. We have all the curry houses in Tooting. So the best curry in London is when you come to Tooting for that, although people in Brick Lane might argue otherwise. So St. George's has been around for a long time, since 1733. We were in an old building, and we have some famous people. Edward Jenner, who introduced the smallpox vaccine, Henry Gray, anatomist. So we like to feel important. We're surrounded by lots of historical people. But the old hospital is now in a luxury hotel, a bit like the Taj. So if you ever come to London and you want to experience, St. George's, this is the executive suite in the former St. George's Hospital. I think it's pretty cheap by Mumbai standards. I think you can afford. So if you stay in that place, that might have been one of the operating theatres in the old St. George's Hospital. So moving on, this is the most important slide over the next 2 weeks. Okay, this slide here. I have medical students that come to my clinics every week, and they're fourth-year medical students, and I always ask them, I said, give me 3 factors that will influence your choice of curative treatment for any patient with any cancer, any solid. It doesn't have to be head and neck cancer. And they always start off, they go, well, the grade of the cancer, the stage, where it's spread to. And I tell them, you only have 3 factors, so you've used up your 3, okay? And I go, any more? And, maybe the patient's age. But I think the most important thing you need to realize is that the cancer belongs to a patient, okay? Don't forget that. It's very easy to get sucked into the molecular biology of the lung cancer you're about to treat, or you get sucked into all the wonderful robotic surgery that you can do for your patient. But don't forget that patient factors, what the most important things you need to consider when you're going to treat a patient with cancer, in addition, obviously, to tumor factors and treatment factors. So those are the only 3 factors you need to consider. With this slide, you have basically all the knowledge you need to in any cancer MDT, because this is what we talk about every single day when we talk about cancer patients. So you can see within patient factors, comorbidities and performance status are important considerations. And what is a comorbidity? It's very simple. It's a separate disease entity, in addition to your cancer diagnosis. And it's important because the actual prognosis from the comorbidity itself could affect the survival of that patient. And the side effects of your cancer treatment can actually make the comorbidity worse. So you need to take all those things into consideration. So hence, it now makes your management decisions more complex, and it is associated with worse outcomes. And the other thing to consider is that as you get older, comorbidities increase with age. Okay, so cancer increases with age. The older you are, the more likely you are to have cancer. Likewise, comorbidities increase in age. So these are your typical patients who smoke, maybe drink a lot, and are elderly, and they're going to have a number of comorbidities in addition to that. So you can see how comorbidities really important factor when deciding on cancer management. And if you want to be a bit scientific, you can try and divide or stratify comorbidities into 3 groups. Diagnostic comorbidities, so comorbidities that might influence the timing of your diagnosis. So you have a patient who you suspect has got cancer, but you're not able to get a diagnosis because the comorbidity limits you in being able to do, say, for example, diagnostic surgery. It may affect the treatment you offer your patient, so that's a therapeutic comorbidity, or it may affect the prognosis, overall prognosis of that patient. So this is a good paper, which I would recommend if you get a chance to read. So I've put the titles, the authors, and the dates, so you can go back and read a little bit more. And what they've done is they've looked at, I think, 17,000 cancer patients, different tumor types, breast cancer, prostate, head and neck, colorectal. And what they found was that regardless of the cancer, and these are patients who had radical treatment, so with curative intent, they found that the comorbidities strongly influenced survival in a dose-dependent manner. So the more comorbidities you had, the worse the overall survival. And this was independent of the stage of the cancer. So even if you had patients with early cancers, if they had more comorbidities, overall survival was worse. The thing to bear in mind when you're looking at various papers on comorbidities or performance status is you just have to ask the question, where has their data source come from? Because you might get patients who report their comorbidities. That is not always accurate. You may go to the medical charts. That's usually a bit more comprehensive. Some of these papers publish administrative data. So this is data that's been collected for millions of patients, but on basis of ICD-9 or 10 classification, so they don't always have all the information. You also need to consider whether or not they've looked at a general population or a disease-specific population. So if you're thinking of treating your patients with colorectal cancer and you're looking at a paper on the influence of comorbidities in colorectal on patients with cancer, you need to ask yourself the question, have they looked at colorectal cancer patients? You need to look at the number of comorbidities measured. Most of these papers have a defined list of comorbidities. Well, as you know, the list can be endless. And you also need to look at the population measured. So we're going to briefly touch on this paper by Charlson. This is going back, it wasn't published in 1986, it was published a lot, I think, back in the 40s. And basically what they did, this is the first sort of scientific look at measuring comorbidities. So they developed this back in the 80s, and they looked at a number of health conditions and gave it a weight. They gave it a score, depending on the health condition. So this is what they initially looked at, things from congestive heart failure all the way to AIDS, and they gave it a score, and depending on the score, they looked at your probability of surviving 10 years. And what they basically found is the higher the score, the worse the survival. And there are these good calculators online. So if you go online and you're thinking you've got a patient, it's age adjusted. So if you know the age of your patient and you put in the comorbidity, it will give you their 10-year survival. So that's very useful information, because if you've got a cancer that might have a 50% survival with the best treatment out there, and you plug in your patient's comorbidities and they have a 2% survival at 10 years, you might want to reconsider whether or not you should be putting them through radical treatment. So you can see why this is important. Obviously, the original Charlson paper, that's the landmark, that's what a lot of people use. What then happened is another group basically looked at updating that, because they identified that a number of diseases which originally back in the 80s were probably incurable, such as AIDS, for example, or HIV. As time has gone by, those diseases were not as life-threatening. So they looked at a number of different conditions, and what they basically found, this is another classification system, the Elixir Comorbidity Index. They looked at over 1 million patients, almost 2 million patients, and they included things like obesity, weight loss, drug abuse. So this is just to highlight that there are different systems out there. There's the original, the Charlson, the Elixhauser classification, and you just need to understand that depending on what you're trying to get out of them, you have a number of choices. And what this paper found was that the Elixir index was superior as a comorbidity adjustment, risk adjustment tool for colorectal cancer survival because it had more conditions within it, and it had obviously looked at more patients. So just touching briefly on comorbidities and oncology trials, it is important to bear in mind that a lot of what we base as gold standard treatment in cancer is on the basis of, you know, sometimes large-scale randomized controlled trials, but they have very tight inclusion-exclusion criteria, and a lot of patients with comorbidities are excluded. So you do have to think about the generalizability and the usefulness of those trial data when you're thinking about the wider population, especially if you have patients with comorbidities, because the results might not necessarily apply. So performance status is a slightly more sophisticated way of trying to sort of look at comorbidities and its effect on the patient. So essentially, it's a way of estimating a patient's ability to perform activities of daily living without the help from others. And it's a bit more refined as opposed to just saying, well, I will not list patients with diabetes in my trial of XYZ drug. You can look at performance status instead, and you know that when you're comparing trials or you're comparing treatments, if you've mentioned that you've only included patients with a particular performance status, you have commonality between those interventions. So it allows us to standardize things. And this is the kind of activities of daily living that you want. So if you think of batted, now this is an American slide, which is why it's baseball. I understand you have a great game here called cricket, something like that. So it's very popular. There's someone called